Welcome to this series of interviews with the giants of cardiothoracic surgery. My name's Joel Dunning, and I'm delighted to be here at EACTS in Milan with Professor Douglas Wood. You're chief of the Division of Cardiothoracic Surgery at the University of Washington in Seattle, and you're the endowed professor of lung cancer research. But most people will know you for your many years of leadership in cardiothoracic surgery. You've been president of the Seattle Surgical Society, president of the Western Thoracic Surgical Association, and a lot of people know you for the Society of Thoracic Surgery, where you're the immediate past president. A lot of people have heard you talk on a wide range of issues affecting all cardiothoracic surgeons worldwide, but we'd like to talk to you about your operative techniques, because you trained at Harvard University, Massachusetts General Hospital, and Sydney, Australia, before coming to Seattle. You were a co-principal investigator on the NET trial, and that was a landmark trial that defined the role of lung volume reduction surgery for emphysema, as well as performing the largest cost-effectiveness study of any surgical trial, and that was published in the New England Journal of Medicine. You also have developed a large surgical airway program and also an interventional bronchoscopy program, and you're a specialist on extended resections, including Pancoast tumors and carinal surgery. And you're also a principal investigator on an endobronchial valve study. So it's these clinical things that I'd love to talk to you about first. So perhaps if we start with a sleeve pneumonectomy. I do thoracic surgery, but I have to admit I've never done a sleeve pneumonectomy. And you know, I see a lot of CT scans and things, but I wonder, could you give us some advice and tips? I mean, how do you spot someone that just might be suitable for such a large operation?
Well, Joel, thank you for the kind introduction. And I think that you're in a situation of many thoracic surgeons who certainly know about sleeve pneumonectomy or carinal pneumonectomy and yet haven't had an opportunity to do one. It's an uncommon operation, and appropriately so, because although one can maybe technically do the operation, it's not always appropriate clinically or oncologically just because it's technically feasible. I'd say the most common patient that you might see that would be appropriate for consideration of carinal pneumonectomy is that patient with a very central right upper lobe tumor that involves the right tracheal bronchial angle that might otherwise be considered unresectable because of proximal involvement of the airway to the carina and even involving the distal trachea. But doing a carinal pneumonectomy allows at least the opportunity to accomplish a complete resection in even those patients that would otherwise be considered unresectable.
So perhaps in your practice you see a right upper lobe tumor, it looks like it's contacting the trachea, and is there any other tests you do? I mean, is a CT enough, or is an MRI help? Or?
So I don't think any extra imaging is useful. I think a CT, and obviously PET to help with staging, but CT is what you need for the anatomy. But it's not the only thing that you need in terms of that assessment. Many of those patients might be feasible for a standard pneumonectomy or a sleeve lobectomy, much more routine operations than a carinal pneumonectomy. But, for example, a bronchoscopy helps to assess the endoluminal extent of tumor. And if you have a very short potential right main stem stump, I think it's better to do a sleeve resection than to try to have a high tension right main stem stump. And you get a better surgical margin.
Now, I'd always worry a lot about them having positive N2 disease or even N3, some lymph nodes on the other side. How would you, but then if you did a mediastinoscopy a week before, then I mean, it's all going to be stuck. So how do you address those N2 or even N3 nodes?
Yeah, I think it's a very astute question on two fronts. One is the oncology front, which is the role of an extended operation, a higher risk operation for patients in terms of staging, as well as the technical aspects of where mediastinoscopy adds or detracts from the subsequent carinal resection. So on the first part, in terms of staging, I personally do not think that a carinal pneumonectomy in my practice, that it's not appropriate for someone with N2 and absolutely not N3 disease. So mediastinoscopy is a critical part of that assessment to rule out N2 disease. Now, the thing that one has to be very careful of is the definition of N2 disease in these patients, because they have a central tumor, and in fact, as mediastinoscopy can usually directly get to the central tumor and potentially biopsy that and mistakenly define somebody as N2 that's really just the primary tumor. So that's an important aspect to understand. The technical side is I always do mediastinoscopy at the time of the planned resection for a carinal resection for exactly the reason that you said. A mediastinoscopy actually develops some of the important tissue planes that helps with the carinal pneumonectomy. So doing it at the time of surgery is actually an adjunct to the operation. And as you pointed out, doing it some days ahead of time creates an inflammatory process, an edema, or adhesions that actually substantially complicate the ability to do a tension-free anastomosis. So mediastinoscopy, I think, should always be done at the time of carinal pneumonectomy. But I want to make one other point about mediastinoscopy is we talked about bronchoscopy assessing the endoluminal extent of tumor. Mediastinoscopy is a minimally invasive tool for assessing the extraluminal extent of tumor. So before one commits the patient to a thoracotomy and attempted resection, you can actually assess the tumor involvement along the lateral aspect of the airway and make determinations about resectability often before you've committed the patient to the major part of the operation.
I mean, maybe this is jumping ahead a slight bit, but is there a kind of distance in which it becomes too much, really? I mean, there must be. Yeah.
There certainly is in my mind, and it's a little different than how I calculate acceptable distance for just a sleeve tracheal resection, a primary tracheal resection, where you can resect up to about half of the trachea oftentimes, or 5 to 6 centimeters. Around the carina, and now I'm particularly talking about a right carinal pneumonectomy, which is the most common. There's less mobility of the left mainstem to really reach high up if you've done an extended resection of the distal trachea. I consider 4 centimeters to really be the limit of airway resection for carinal resection. And I do careful measurements with during the bronchoscopy to assess that.
Yeah, and are there any good release maneuvers for carinal pneumonectomy?
There are. For distal airway surgery, so distal trachea or carinal surgery, I think a routine aspect of airway mobilization and release is a hilar release. So obviously mobilizing the pulmonary ligament, that's the first step of that, but actually incising the pericardium around the inferior aspect of the inferior pulmonary vein, that actually allows the whole hilum of the lung to rise up about 2 centimeters, so take some of the tension off the distal side of the airway anastomosis. And then on the proximal aspect, just this development of the pretracheal plane, which is accomplished by the mediastinoscopy in an efficient fashion, provides the proximal aspect of airway mobilization. I do not think there's any additional benefit of going more proximal and doing, for example, a suprahyoid release like we might do for a proximal tracheal resection. That really does not add any useful distance around the area of the carina.
Yeah, so you've done your bronchoscopy and spent a long time on the mediastinoscopy, releasing things up, and now you're ready to perform the operation. But the anesthesia, I imagine, must be a little different. What are the extra tools that they use with you to help you do this?
The majority of the anesthesia is the same as with any major thoracic procedure, epidural, appropriate monitoring. But the things that are unique, and it's very important that the anesthesiologist and surgeon have discussed ahead of time how the airway is going to be managed. I strongly prefer a long single lumen endotracheal tube rather than a double lumen endotracheal tube. Double lumen endotracheal tube is just too bulky during the period of time when you're then doing the anastomosis, which we may talk more about a little bit later. So a long single lumen tube that goes into the left main stem bronchus is a very nice way to do single lung ventilation that is less bulky and is then easier to reestablish during the time of the anastomosis. Because during the time of the disconnected airway, we actually do cross-field ventilation, and the anesthesiologist and nurses have to be prepared with the appropriate equipment for that.
And do you ever use some jet ventilation at all, or is that not such a useful tool?
Well, I do not use it for the vast majority of the operation. I don't really like jet ventilation. I think that it aerosolizes blood and secretions and kind of is messy in the surgical field. It has the benefit of being very low profile and thin, and that's easy, but I don't like the noise and the kind of aerosolization of blood. And so during the vast majority of the procedure, I do just a single lumen tube into the left main stem bronchus that's controlled across the surgical field. We can take that in and out while doing the anastomosis. But I have found I like jet ventilation for one very relatively small part of the operation, and I do it pretty frequently. And this is that period of time after putting in all of the sutures for the anastomosis, just the period of time of tying them. Because during that time, that's when you're trying to keep all the tension off the airway, and just the aspect of having a tube across the airway pulls them apart a little bit. And I like to avoid all of that even less bulk of a single lumen tube just while I'm tying the anastomosis.
So yeah, I suppose we're on the anastomosis issue. How exactly do you use? Are they interrupted, and what suture do you use?
Well, I trained at Mass General Hospital with Hermes Grillo and Doug Mathieson, and I use the classic Grillo style of anastomosis, which is interrupted forovicral sutures, so a braided, absorbable suture. I like the knot tying characteristics. I like the ability with interrupted sutures to have a completely open anastomosis for the laying in of each stitch and for the correction of size discrepancies circumferentially. So I prefer that aspect. The harder side of that is what I was just talking about, is then there's this a little bit of an awkward period, I think, where then you're pulling the airway together, and we use traction sutures to help take some of the tension off the airway when doing that, and tying the anastomotic sutures. And that's that period of time that I like a jet ventilator, which is maybe 10 minutes of tying those circumferential anastomotic sutures.
Yeah, but it is absolutely key to get the anastomosis right. Do you wrap it with anything afterwards, or is it tucked away?
Yeah, I always do wrap any of my airway anastomoses, and typically I would just cover it with pericardial fat pad, which is what I also put on bronchial stumps, and I think that is perfectly adequate for most circumstances. In the rare circumstance where somebody's had high doses of radiation and I'm more worried about vascularity, I may bring in a muscle flap or omentum even. Sometimes I'll mobilize omentum to bring into the chest to cover an anastomosis that I think is particularly high risk.
And we got into the chest pretty quickly there in that discussion. A lot of residents sort of tell me, so, just ask these guys, how do you just simply do your thoracotomies? There are several different ways. Do you have any favorites? So some people resect a bit of rib, some people protect the nerves, or just standard posterolateral.
Yeah, I absolutely have a favorite. I have a pretty standard thoracotomy that I've done for a long time that I think gives great exposure even for extended operations like this, and yet has pretty easy recovery for patients. Of course, it's still a thoracotomy. I actually resect a long segment of rib, not just a short segment, because I think that it's the retractor spreading the ribs that provides a lot of the surgical trauma and the pain postoperatively. So by resecting a rib, it allows two things. First of all, there's less spreading of the ribs that are left behind because you've got just more of an opening. But second of all, then when I close it, I do not put pericostal sutures in. I only put interrupted sutures just in the intercostal muscles and the periosteum that's left behind. So I think it has less of an aspect of entrapment of intercostal nerves. And I do it, that's partial muscle sparing, so I usually do a modified lateral thoracotomy that does divide the latissimus, but spares the serratus. I create a small latissimus flap that allows me to retract the serratus anteriorly out of the way, and that keeps all of the serratus function. And then when I put things back together, my residents make fun of me for this, but I actually like several small layers. So, for example, I close the latissimus in 2 layers, not with a single layer, which I think preserves more of the function and does less of devascularization and kind of constricting of tissue layers as you're closing it. It makes a very soft, pliable thoracotomy that the patients, I think, really like.
Right, that's interesting. So maybe we move on to another topic. There's so many we could talk about with you, but I think we can't let you get away without talking about emphysema. Obviously, the NET trial was absolutely seminal. It was ahead of its time by multiple years. But what is the state of emphysema surgery in the USA today?
Well, we're certainly doing emphysema surgery. But it's still, I think it's underutilized. I think there remains a lack of appreciation of the patient indications for lung volume reduction surgery, which offers an enormous benefit for correctly selected patients. And I think that is a perception problem of often the pulmonary physicians and the general medical community that maybe didn't understand the profound benefit shown in the National Emphysema Treatment Trial for appropriately selected patients.
Yeah, and certainly in the best group, the heterogeneous patients with limited capacity, I mean, there is very clear benefits, isn't there?
Yeah, in those patients, there's not only benefit in exercise capacity, pulmonary function, and quality of life, there is even benefit in survival. And so the only other treatment that has shown survival benefit in emphysema patients is oxygen therapy. So there is a subset of patients that have a survival benefit of lung volume reduction surgery, and really it's almost unconscionable that they wouldn't at least be offered the counseling and opportunity to be considered for LVRS.
Yeah, and do you think endobronchial valves will change the game? Or you know a lot about these things, but there's a lot of cross-bronchial circulation, isn't there, cross-inflation, isn't there?
So I've been very involved with endobronchial valve clinical trials, and I do not really think they change the indications for lung volume reduction surgery or replace it. We've learned that they're really a substantially different mechanism of action, and I think that more what endobronchial valves offer is staged therapy for patients with emphysema, or offering options for therapy for patients that might have contraindications to lung volume reduction surgery. I think they are complementary rather than one replacing the other.
And how do you do your lung volume reduction? Stenotomy, VATS, one at a time, two at a time?
So in the United States, one is really, in terms of the requirements from our Medicare provider, for our insurer, it's a bilateral procedure. It's not a unilateral procedure. It's not approved as a unilateral procedure because of really the results of the clinical trials that studied it only as a bilateral procedure. So I always do bilateral procedures. I still prefer a sternotomy, which seems to many barbaric, but I prefer it because of some technical aspects of being able to manually examine the lung, manually pick where I put my surgical staple line. And I like the ability to manipulate the lung and to refine my staple line that I'm more able to do with an open procedure than a VATS procedure. VATS is absolutely a very good procedure for lung volume reduction surgery as well. But interestingly, the outcomes are not substantially different between VATS and sternotomy.
I imagine the major determinant's air leak, isn't it? Is there any good tips? Is it just doing that staple line carefully, buttressing maybe?
There's a couple of tips. Certainly buttressing is useful in these patients. I think being very careful and meticulous with the staple line. When I'm working with residents and teaching residents, what I'm trying to point out to them is a smooth staple line that doesn't have any parenchymal wrinkles and that lines up one part of the staple line with the other, and also uses staple lines along acute lung margins, not broad lung surfaces where as that lung re-expands, there's a lot of tension on the staple line. Even with those steps, most patients have some aspect of air leak postoperatively and sometimes significant, but I think those are ways of minimizing it.
So we're drawing near the close of our discussion, but I probably can't let you escape without at least one semi-political question, and that's what is the future of thoracic surgery in the USA? I know there's a lot of generalists and specialists, but if there's a resident out there listening, I mean, what is the future of thoracic surgery?
Well, I think embedded within that question is the aspect that many different specialties or subspecialties do some aspect of thoracic surgery in the United States. And I think that the future is largely driven by quality and outcomes, and the fact that there's more and more transparency and more understanding of things that lead to best outcomes, both in terms of short-term outcomes, which are easier to measure, complications, mortality rates, but just as importantly, and somewhat harder to measure, long-term outcomes, for example, cancer survival. And thoracic surgery is an area where volume and specialization result in substantially better outcomes. That's been very well shown over and over again in numerous studies. And I think that continues to drive patients and then ultimately payers. In the United States, payers often determine much of this towards those individuals that are, first of all, board certified and specialized in thoracic surgery and have a high volume in the area of interest. In this case, we're talking about complex thoracic surgical oncology operations and emphysema operations. And it's going to a center that does that a lot, and patients increasingly recognize the benefit of being in a high-volume, specialized center.
Well, it's been an absolute pleasure talking to you, and I'm sure for myself and everybody at CTSNet, we have to thank you both for your work with CTSNet as well as the Society of Thoracic Surgery. And I suppose you're no longer president now, so how is your kite surfing going now you've got all this extra free time?
Well, you're funny to bring up my kiteboarding because you know that I've been trying to learn kiteboarding as a new sport, which has been put on kind of on the back burner while I've been president of the STS. And I still have a long ways to go. I need some mentoring and some advice myself, and maybe some of those residents that are listening to this that are good kite surfers could mentor me on how to be a better kiteboarder.
Well, there's an offer. I'm sure you'll get several requests and help there. But for me, Joel Dunning, and everyone at CTSNet, I'd just like to say a big thank you very much.
Joel, thank you.
Yep.